Hi, everyone. Thanks so much for joining today. We're going to give folks just another minute or two to join, maybe just another minute because we've got a full schedule today. So stand by. Okay, I think we'll go ahead and get started. As I mentioned, we have a really exciting and full schedule for today's webinar. So I just want to start by saying thank you to all of you for joining us to talk a little bit about our updated hepatitis C prevalence estimates, which are featured on HepView. We're very excited to have some partners here today to talk about the estimates and their implications for policy and for surveillance. Next slide, please. I'll just start with some brief introductions. For those of you who don't know me, I'm Heather Bradley. I'm an associate professor at the department or in the Department of Epidemiology at the Emory Rollins School of Public Health. I'm also the project director for HepView. So for those of you who have joined HepView events in the past, thank you so much for coming back. And it's great to see you here. We have three exciting panelists today, and I'll go ahead and introduce all of them, and then they can turn their portion of the talk over to the next speaker as we move along. So first, we're going to hear from Dr. Eric Hall, who is an epidemiologist and assistant professor of epidemiology at the Oregon Health Sciences University, Portland State University School of Public Health. Dr. Hall is also a HepView Research Fellow, and his research is dedicated to the prevention and treatment of infections, including viral hepatitis and HIV. His work really focuses on development and use of epidemiologic, statistical, and economic evaluation methods to provide findings with direct implications on public health programs and policy. And so he's going to talk to us about that type of work today, which is creating these new hepatitis C prevalence estimates for the US. Next, we're going to hear from Dr. Risha Irvin, who is an associate professor at the Johns Hopkins School of Medicine in the Division of Infectious Diseases. Dr. Irvin focuses on improving the health of vulnerable populations who are impacted by hepatitis C infection. She serves as Health Equity Program Director for the Johns Hopkins Health System, as well as Vice Chair for Diversity, Inclusion, and Health Equity for the Department of Medicine. Her federally funded research focuses on the impact of hepatitis C testing and treatment in incarcerated persons on hepatitis C elimination in the US. And she currently serves as a member of the National Hepatitis C Elimination Team, which is led by Dr. Frances Collins, who is the former director of NIH. And so she'll really be speaking to us in her capacity as a member of this National Hepatitis C Elimination Team together, or today. And last but certainly not least, we have Dan Church, who is an epidemiologist with the Massachusetts Department of Public Health, where he has worked for over 25 years with a focus on viral hepatitis. So he's been really fighting the viral hepatitis fight hard and for a long time. And we're so excited to have him here today, both in his capacity as a state or a senior state epidemiologist, but also Dan serves as the co-chair of the CSTE viral hepatitis subcommittee. And so he's really going to be talking to us today, about what these new estimates mean for surveillance and for public sector public health. Next slide, please. So this is our agenda. We'll have 3 talks. Dr. Hall will talk about estimating hepatitis C prevalence in the US and give us an overview of the estimates and how we arrived at them. Dr. Irvin will be talking about how these estimates really inform and impact the work that she and her committee are doing to eliminate hepatitis C in the United States. And then Dan Church will be talking specifically about hepatitis C prevalence as it relates to public health disease surveillance. And as we talk a lot about at HepView, the need for better viral hepatitis surveillance so that we eventually will have, some of these basic epi indicators coming from real data rather than from estimates. So next slide, please. I just want to quickly acknowledge the role of our funder here. Eric and I worked together on these hepatitis C estimates with colleagues at CDC, and this work was supported by CDC through a modeling agreement, and that agreement includes both Emory and OHSU, Portland State School of Public Health, as well as a number of other universities that are shown here. So with that, I'm going to turn the first part of the webinar over to Eric. And I do want to say that if you have questions as we go along, if you could please click on the Q&A box and add them to the Q&A as you think of them is fine. You don't have to wait till the end. And then at the end, we'll be moderating some discussion, and we'll make sure to get to those questions then. Okay, over to you, Eric.
Great. Thank you, Heather, for that excellent introduction. And thank you all for taking some time to join this discussion today. I'm excited to be here to be talking about a paper I recently did with Dr. Bradley and other authors in the academic space and at CDC that focused on estimating hepatitis C virus prevalence in the United States, reflecting the time period of 2017 to 2020. Next slide. And to get started, I want to quickly take a look back at the last time we estimated national HCV prevalence, because this new paper that recently came out is really an update and an extension on previous work that has been done in this space. And so prior to this paper, the previous estimate of national HCV prevalence was published in 2019, and this paper highlighted in the top right here, led by Megan Hoffmeister from CDC. And this paper was tasked with estimating both antibody and HCV RNA prevalence among all US adults 18 plus years of age, and it reflected a time period of 2013 to 2016. And so I have a simple diagram at the bottom here that outlines kind of the approach and methodology that was used in this paper. And it was really built upon data that comes from the National Health and Nutrition Examination Survey and NHANES, and then supplemented with a few additional data sources. So many of you are probably familiar with NHANES, but NHANES is a large national survey that has complex sampling methodologies that is designed to represent the non-institutionalized population in the US. And so that's a great data source for that particular sampling frame. But of course, when thinking about hepatitis C virus and folks that are impacted by HCV, that sampling frame does not include a few key populations. And so we use data from NHANES to reflect that non-institutionalized population, and then added in additional data that represent 4 key groups that are not part of that sampling frame. So the incarcerated, unsheltered, unhoused, nursing home residents, and active duty military. And the math behind this was relatively simple. We essentially identified population size estimates for these 4 groups, and then conducted large literature reviews and meta-analyses to estimate prevalence within each of these 4 groups, multiplies those together to get the total number of infections, and added those into our infections that were estimated using NHANES. Next slide, please. And so this is the key table of results from, again, that previous paper. I've highlighted the number on there that I'm sure you are all very familiar with, which is the primary estimate of 2.4 million persons that were positive for HCV RNA prevalence, again, reflected this time period of 2013 to 2016. If you look at this table, you can see there's also antibody prevalence estimates to the left, And then, up above the highlighted result are prevalence estimates, again, from the NHANES data reflecting the non-institutionalized population, and then those 4 additional groups that are not part of that sampling frame. Next slide, please. And so, again, this national estimate has been widely used in, a lot of our academic studies, a lot of our, national planning approaches. And, we recognize that the use of this estimate now, in present day, there's a few limitations with currently using this. And these are the limitations that we aimed to resolve or better address with this new paper. The first is quite simply, the data is pretty outdated. As I mentioned, that previous estimate was built on NHANES data that reflects 2013 to 2016. It included population size estimates for those 4 additional groups that all reflect 2016. And the literature review and meta-analyses that I referenced all use prevalence data from literature that was published between 2013 and 2017. So quite simply, the data behind that estimate is just a little bit old now. And then the second and possibly more important piece that we wanted to think about is the idea that persons who inject drugs, or PWID, are not adequately represented in NHANES. So the NHANES sampling frame technically does include people who inject drugs. However, we can think of a variety of reasons why PWID may not end up in the final analytic data set. They may be less likely to participate in NHANES when sampled, or they may be less likely to provide blood specimen to be tested for HCV antibody and RNA. And so there could be, the essentially persons who inject drugs, while eligible for the sampling frame, may not be represented in the final data that we actually analyze. And then, of course, among those that are included in our data, HCV prevalence among that group, among PWID and NHANES, may not reflect HCV prevalence among all non-institutionalized PWID. And so really this limitation is a piece that we tried to focus on here and try to advance our methodology to better account for persons who inject drugs in our national estimate. Next slide, please. And so that led to this 2-step approach for this new paper and these new estimates. And the first is essentially updating the previous approach with more recent data. And so that's highlighted number 1 here. I'm going to be referring to this approach as the NHANES Plus model, but we essentially replicated that same previous methodology that was used in the 2013 to 2016 estimate and others before that with more recent data. So for that, we used the most recent NHANES data set that reflects 2017 to March 2020. We used the most recent population size estimates for those same four additional populations, and we conducted new literature searches and new meta-analyses for HCV prevalence studies that were conducted among these 4 additional populations, and all of those have been published since January 1st, 2017. And then second, we developed a new method that's an extension of the work that we've been doing. I'm referring to it here as the PWID adjustment model, again, to better reflect infections among persons who inject drugs and try to address that second limitation I just discussed. And there are a couple new-ish or now available data points that enabled us to do that. And these are key data points that fed into our estimation process here. The first being in a paper led by Dr. Bradley, who's of course moderating this discussion, that estimated in 2018 there were 3.7 million persons who inject drugs. So we now have an estimate of the total number of PWID in the US that we can use as part of this Hep C prevalence estimation project. And then the second, there was a large meta-analysis conducted by Degenhardt and other authors in 2023 that estimated HCV RNA prevalence and antibody prevalence, specifically among persons who inject drugs in the US. And so from that meta-analysis, those estimates were 43.7% and 53.5% respectively. And again, these are additional data points or key data points that we use in this P-Wood adjustment model process. Next slide, please. And so here's a diagram of that P-Wood adjustment model. It looks more complicated than it is, but you will see, from the top half of this, it is very similar to our NHANES Plus model. And then there's an extension in that second line in which we essentially separate out those groups, the non-institutionalized, the incarcerated, the unsheltered, unhoused, into P-Wood and non-P-Wood. And so the key assumptions here that we're making through this process is that we are assuming, again, there were 3.7 million people who injected drugs in 2018, and those 3.7 million were distributed among the non-institutionalized, the incarcerated, and the unsheltered, unhoused. I want to point out that that's our point estimate, and of course, we have a confidence interval around the estimate of the number of P-Wood, and that confidence interval is incorporated in our quantification of uncertainty in the resulting HCV prevalence estimates here as well. So that's, the key assumption number one. And then, as I mentioned, those P-Wood are distributed across those three groups. And then in order to distribute them across those three groups, we needed to know something about the proportion of incarcerated that are P-Wood and the proportion of the unsheltered, unhoused group that were P-Wood. And so we identified the most recent estimates of that we could find, which were 10.6 of the incarcerated and 7.4 of the unsheltered, unhoused, were P-Wood during this time frame as the key inputs for our primary results. I'll note, I'm not going to talk about it today, but it's in the paper. We relaxed these particular assumptions in sensitivity analyses to try to get a sense of how much these assumptions are impacting the overall prevalence estimates. And the main takeaway is they don't impact it very much. But again, so through this P-Wood adjustment model, we're better accounting for the number of persons who inject drugs. We're applying that elevated HCV prevalence estimate from the meta-analysis to those P-Wood, no matter which of these three particular groups they belong to. Next slide, please. And so here is the primary results from this new paper. To orient you to this table a little bit, the top half of this table in white, those are HCV antibody prevalence results. And then the bottom half of this table in the, I guess that's kind of a green color, those are HCV RNA prevalence results. And so within each of those, what you see here is we just report the results from that previous Hofmeister paper that I mentioned that reflects the 2013 to 2016 time period. And then we report results from our NHANES Plus estimation process, which again uses the same methodology as that Hofmeister paper, just with updated data sources. And then we present the results from the newly developed P-Wood adjustment model that I just described. And so if you look right in the middle of this table, down in the center, looking at HCV RNA prevalence results, there is the 2.4 million from the Hofmeister paper that I previously mentioned, using updated data, but that same methodology in our NHANES Plus model. That number is pretty similar. It's about 2.46, maybe 2.5 million. And then using our P-Wood adjustment model, we estimated there were about 4 million persons who were HCV RNA positive from this time frame, or between this time frame of 2017 and 2020. Next slide, please. This is a graphical abstract that is published with this paper, and it contains a lot of the information that I just talked through. It's just a little bit more visual and a little bit more concise. And so the way you can read this, the top half, if you work your way across, that is all referring to the NHANES Plus model. And then the bottom half, that's all referring to the P-Wood adjustment model. And so working from left to right, there's a little bit of details that summarize each of these models. There's the primary results, the corresponding number of estimated infections. And then I want to draw your attention to the conclusion section over on the right-hand part of this slide, because I think it can be a little bit difficult to interpret the results of these two estimation approaches or these two models together. And they both are important to think about. And so the way I would summarize, the way we did summarize the results from these two are First, despite years of an effective cure, estimated prevalence of hepatitis C in 2017 to 2020 remains unchanged from 2013 to 2016 when using comparable methodology. And then, when accounting for increased injection drug use, estimated prevalence of hepatitis C is substantially higher than previously reported. Next slide, please. And so I quickly just want to acknowledge everyone that contributed to this project. These are all co-authors and people that supported this project. Several folks from Emory University, and then several collaborators at CDC, many folks from the Division of Viral Hepatitis and the center at large. And obviously this was a very large project that had great collaboration across all these institutions. Next slide, please. And with that, I will pass it over to Dr. Irvin.
Thank you so much. Again, thank you for having me today. I'm Risha Irvin, and I'm currently on an Intergovernment Personnel Act to the NIH, where I report to Dr. Francis Collins, who leads the National Initiative to Eliminate Hepatitis C. Other members of our team are Drs. Rachel Florence and Dr. Josh Sharfstein. Next slide. Today, I want to give a very brief overview of the National Initiative on Hepatitis C and where it stands, and then really speak to the impact of the updated hepatitis C prevalence estimate on the national plan. So there are three major components when we break down the overall national initiative. The first major component relies on point-of-care RNA diagnostic tests to really enable hepatitis C single test and treat programs to enhance the cascade of care. These tests can be really integrated into outreach settings, for example, to avoid having to do a rapid antibody test and then sending an individual somewhere else to have an RNA test to be done. As we know, this represents a barrier to care and oftentimes leads to loss to follow-up when we can't tell someone that they are chronically infected. I'm pleased to say that these tests have now been FDA approved and can be incorporated into settings, in particular outreach settings or settings with kind of rapid turnover. The second part of the plan is really focused on providing broad access to curative hepatitis C medications. In this part of the plan, the federal government purchases the medications for a fixed sum and then provides those medications free to Medicaid, uninsured persons, incarcerated persons, individuals in opioid treatment programs, and individuals getting care from Native American reservations. We have had barriers in our country around the cost of medications, fibrosis restrictions, et cetera. And this is really meant to open up access for marginalized populations that have encountered barriers when we think about medication access. The third part of the plan, and the final part, really focuses on how we empower healthcare delivery. Having medications alone is not enough, and I think we all know that. We have to really meet people where they are and find individuals that may not have many touch points with the medical system. This part of the plan focuses on expanding screening and treatment settings, including settings such as correctional settings, opioid treatment programs, emergency departments, mobile units, et cetera. It also has a focus on innovative telehealth models and really empowering community health workers as well, because we know that we'll need more support as we go out to screen and treat individuals, and in particular, thinking about how we can improve the care cascade for marginalized individuals. Next slide. So just want to touch on the status and kind of where we are on the national plan. So it was initially proposed back in March of 2023. There's been strong federal agency support across multiple agencies, and a detailed 5-year implementation plan has been developed. There's been a strong advocacy around this effort, with many organizations coming together to sign letters to Hill leadership. Legislation has been composed, led by Senators Cassidy and Van Hollen, so really a bipartisan effort. There's also been other bipartisan congressional support. There have been several models that have been developed as well, showing cost savings in 10 years with significant reductions in liver fibrosis, cirrhosis, liver cancer, and the need for transplants, all of the things that we would really expect. Next slide. So what many of you may have seen recently, the Congressional Budget Office published their initial analysis of Medicaid cost savings. This matters a lot in terms of kind of the bill. So the CBO estimates that 100% increase in Medicaid enrollees treated for hepatitis C would reduce federal spending on healthcare by about $7 billion over 10 years, so showing that kind of cost savings. But we actually think we can do much more. And when you think about it, with the availability of the point of care tests, implementation of the subscription model, and really empowerment of healthcare delivery, we believe that a 200% increase is entirely achievable with the right components in place and with the work of all of you, of course. So what I want to turn to now is to briefly touch on how the updated hepatitis C prevalence estimate impacts the national plan as we think through the PWID adjustment model. So first, I think it's really important because the model acknowledges the underestimate of PWIDs in prior estimates. The increased estimate of PWIDs included with hepatitis C infection really reinforces that the national plan has the right approach with a strong emphasis on PWIDs and meeting individuals where they are and including in correctional settings, opioid treatment programs, and in settings focused on individuals who are unhoused and unsheltered, as we know they have a higher prevalence of PWIDs. The national plan also relies heavily on community health workers who will be needed to support outreach for marginalized populations to help overcome barriers to care. Next, there's been this continuous debate on how much we can really increase hepatitis C testing and treatment beyond the status quo. And it affects kind of the modeling around the elimination metrics and also the cost savings. And current models have been based on that 2.4 million prevalence with chronic hepatitis C is what's been used. So the increased numbers accounted for in the model, the PWID model and the adjustment, make it all the more doable to increase hepatitis C testing and treatment to 200% above the status quo if we are in the right venues and doing the correct outreach, because then we know that the individuals are there. And thus revised estimates on hepatitis C elimination and cost savings can account for the higher prevalence and show really what can be achieved. I think having this new estimate on hepatitis C prevalence really helps us move this work forward and gives us what we need to measure our impact, the decline in HCV viremia, and elimination metrics. I'm really excited about this work, and it was great to have this updated prevalence estimate. I'll now turn the floor over to Dan Church. Thank you so much.
Great. Thank you so much, Dr. Urban, and thanks to the organizers of HepView for inviting me to participate in this webinar and to talk about this really important research. I'm going to be talking about the role that public health disease surveillance plays in understanding hepatitis C prevalence estimates and to move us towards hepatitis C elimination. Next slide. And so starting with the obvious, if we are going to eliminate hepatitis C, we need to have the most accurate hep C prevalence estimates that we can in terms of really understanding where we are with this disease and how we can achieve elimination both nationally and at local and state jurisdictions. Unfortunately, current national hep C surveillance infrastructure is really not adequate in most cases to really understand prevalence estimates fully, although it does give us a lot of important information and can be used as a tool for moving us towards elimination and developing localized prevalence estimates. Next slide. So even though I've said that it is very limited hepatitis C public health surveillance, even with those limitations, we still see a very high number of cases being reported on an annual basis throughout the country. And in 2022 alone, there were almost 94,000 newly reported chronic hepatitis C cases reported by states and local jurisdictions to CDC. And as was suggested in Dr. Hall's talk, there were previous estimates that were based on NHANES data that came out to try to better understand what is happening with hepatitis C prevalence. And in the past, those really didn't match up very well with what we have seen in our state and local jurisdictions in terms of the numbers of reported cases. And so those were difficult to parse. And I think that's why this research that has been presented is really so important. You know, in the past, for an example, in 2016, the most recent NHANES prevalence estimate that was available at that time, which precedes the ones that Dr. Hall talked about, we had the total number of reported cases in Massachusetts being 3 times what those prevalence estimates would have been. And that did not obviously then include those folks that were not in our data who had not yet been tested and reported to us. So we've really seen that the previous national estimates have not been adequate for understanding what is really happening. And so these new estimates, I think, really do a much better job in aligning with what we're seeing with the data reported to state and local jurisdictions, and by correcting for those that were just excluded previously from NHANES sampling and those that do meet the inclusion criteria but are less likely to participate, as Dr. Hall went over. And one of the really important aspects of this paper also was in the discussion where the authors addressed some of the current limitations of public health surveillance very accurately and appropriately. Next slide. And so the primary limitation of hepatitis C surveillance is funding, and that there just really isn't sufficient funding to meet the amount of work that is posed by the volume of cases reported to state and local jurisdictions. And because we do not have sufficient funding, this means that we do not have complete data. And very importantly, that we do not have, we miss opportunities to link people who are reported to those jurisdictions, to link them to care and for testing and treatment as they may need. Another limitation of current hepatitis C surveillance is that not all jurisdictions require reporting of negative hep C RNA test results. Many do, but not all. And so you really can't determine the prevalence of the population you're measuring without knowing who has cleared the virus from their system, either through treatment or spontaneous clearance. The newly approved point of care HCV RNA tests that Dr. Irvin talked about, I think are really pose a very exciting opportunity. They also pose an additional challenge to viral hepatitis or hepatitis C surveillance, as those results are going to be very challenging to capture in current surveillance systems, as most of the cases that are reported to health departments usually start by having a laboratory automatically report those through an automated feed. And so without that, other systems are going to be needed to capture those data. And that is something that the Division of Viral Hepatitis is thinking about, as well as the CSTE. Another limitation of surveillance just generally is that the cases that we have are the people who received care, got tested for hepatitis C, and then reported to that jurisdiction health department. And so if people do not do that, they are not in our data. So we are always limited by those folks who did not receive the care that they need. And also with very high volume diseases like hepatitis C, doing individualized case investigations are very complicated and very resource intensive. And so they're often not going to be adequate without more resources. Next slide. But even so, even with those limitations, we have tried to address them by improving how we conduct surveillance that will better position us for understanding the true prevalence in a jurisdiction. We've done that by revising case classifications and with individual jurisdictions prioritizing investigations. In case classifications for nationally notifiable conditions, meaning those that are reported by state and local jurisdictions to the CDC, are developed in collaboration with CDC subject matter experts, in this case from the Division of Viral Hepatitis, and then approved by the Council of State and Territorial Epidemiologists, or CSTE. And current Hep C case classifications were implemented at the beginning of 2020 And the goal of those revisions was to increase the sensitivity of acute case capture. But really, the primary issue was that we wanted to focus on cases with evidence of current infection. And that way we could be better at measuring the actual prevalence of cases in a jurisdiction. Next slide. So this is just to give a visual of what we're thinking about with prevalence with cases that are reported to health departments, where this bucket in the center of the slide really is the prevalent cases, the number of people with chronic hepatitis C in a given jurisdiction at a point in time. And then you are adding to that prevalence when you have new infections, mostly through injection drug use, more rarely through healthcare exposures, but we also want to capture those cases that have been reinfected, as well as perinatal transmission. And then the people who come out of the bucket are those that have been treated and cured, thus reducing the overall prevalence, people who spontaneously clear an infection after their acute illness, people who have died either of hepatitis C or other causes, and people who move out of a jurisdiction, so they are not needing to be measured. And I think it's important to point out that throughout all of this, there are health equity considerations that need to be addressed, both in terms of who is having access to prevention services that can help them stay uninfected in the first place, as well as those who are already infected needing to have access to testing and treatment services. Next slide. So we've talked about some of the limitations of surveillance, but I think it's also really important to think about what surveillance can give us with an elimination effort. And with adequate funding, we can really obtain high quality and much more complete population-based data. So we're actually having the actual measurement of prevalence and not just relying on estimates. But having those data will also allow us to identify those chronic hep C cases that need to be linked to additional testing and often treatment and cure. We need to be able to identify clusters of acute hepatitis C cases so that we can address those new cases that are adding into the prevalence in a jurisdiction. We need to be able to figure out who is not getting services and prioritize populations for testing linkage services, thinking about health equity and who needs to get access to care that does not have it now. And thinking about local and regional prevalence estimates and comparing them to national estimates, such as the one that Dr. Hall described, and how well a jurisdiction is doing either in measuring those cases or in eliminating hepatitis C for the individuals in that jurisdiction. It's also important to determine co-infection prevalence, especially for hepatitis B and HIV. And then, of course, to evaluate efforts to eliminate hepatitis C infection. How well are we doing in addressing the needs for elimination in the jurisdiction? Next slide. So just to give an example of what how these data can be used, this is a recent study that was done by my colleague, Petra Schubert, and this is looking at the laboratory-based Hep C clearance cascade from 2014 to 2022 in Massachusetts. The first bar represents all of the individuals that were newly reported during those years. The second bar represents those that either had viral testing or not. The third bar shows of those folks who had viral testing, how many of them were positive and how many were negative. The fourth bar shows those that had positive viral testing and how many were cured or cleared and how many remained infected. And then the final bar indicates those that had persistent infection or reinfection. Next slide. And so I bring this up not to show what's going on in Massachusetts so much, but really to show what can be done with data like these. And that you have in the second bar here, 13,000 people plus who need a confirmatory test who did not receive it during the time period that we were studying. And then in the fourth and fifth bars here, you can see that there were over 31,000 people who still need to be treated and cured of their hepatitis C infection. So these are all individuals that we have information on, and we need to do more to make sure that we are addressing their healthcare needs. Next slide. So where do we go with this? Obviously, we need to continue to strengthen our surveillance systems and our surveillance policy, and thinking about not just what we know, but how well we know it. We need to continue to validate our data streams to make sure that the data we are receiving in state and local jurisdictions is accurate. Assessing what we don't know, especially thinking about how do we estimate prevalence? What is the prevalence in a given jurisdiction compared to what we would expect to see? Making sure that jurisdictions across the country are able to receive negative test results for hepatitis C so we can really understand prevalence for their areas. Looking at claims data to better understand treatment access, and improving ascertainment of race and ethnicity so that we can identify health equity issues and address them. And then finally, also ensuring reporting mechanisms for novel diagnostics, especially this newly approved point of care HCV RNA test. Next slide. So I think as we continue along the path of hepatitis C elimination, it's going to become more and more important to have systems like this in place, because if we're going to get people diagnosed and treated in a timely way, it's going to become more and more challenging because we're going to need to continue to target those who are less likely to be engaged in care, and then also at higher risk of reinfection. And this would be best achieved with population-based surveillance data, especially with individual case investigations and active linkage to care. And we need to continue to think about what is happening with national estimates through high-quality research that Dr. Hall described, and thinking about what is being missed in our different jurisdictions and nationally, and what is the best way to address those needs, and thinking about as creative strategies to address those needs, to understand our data, to improve our data, and evaluate and adapt. Next slide. And that is all I had. And I also just want to acknowledge my colleague, Tony Osinski, who developed a number of the slides that I used today. And thanks again to the organizers of the webinar.
Thank you all for those excellent presentations. I'm so happy that we could bring together these three unique perspectives on the new hepatitis C prevalence estimates today. You all provided just very informative and thought-provoking talks. So I know I speak for everyone when I just thank you again for being here and for giving those talks. We're going to move now to a Q&A section. Before I go to the Q&A, I would like to turn folks' attention to the Q&A. There's a sort of like a comment symbol with a question in it at the bottom of your screen. And so if you have questions, please place them there. A couple of people have had questions during the talks today that have already been answered, and you can see those in the answered section. So just want to make sure everyone has access to that information. So our first question from participants that came in that has not yet been answered is from Dan Shappy, and I'll read it and then turn it to our panelists to answer. So the question says many state Medicaid, health plans, which helps, help to care for marginalized patients across the country, have removed prior authorization criteria for Hep C treatment. Some have not, such as Maryland, South Carolina, and others. Do you feel states with prior auth requirements make it more difficult to treat patients to clinical cure? And do you all know of any data available comparing states with and without prior authorization requirements? And just particularly in terms of ability to treat marginalized populations with high prevalence of hepatitis C. I'll open that up to our panelists.
I'm happy to start. I think it has been documented that when we have these barriers that it's harder to get through the care continuum. So there is data there. Many of our states have scaled back over the years in terms of those. In Maryland, for instance, we used to have restrictions around fibrosis, around what provider could prescribe, and sobriety. All of those have gone away, which has made it much easier to kind of function in the clinic and kind of write your prescription and kind of know that it's going to get to the patient. We used to lose a lot of patients kind of in that process where we were going kind of back and forth with kind of prior authorization and trying to appeal those decisions. So I think it's really great when we can get rid of all of those kind of barriers that prevent people from getting medications. One of the things I'll say as well is if the national plan is implemented, any state that opts in would have to drop all prior authorization. So prior auth would not be kind of a barrier under the National Hepatitis C Elimination Plan.
Thank you so much. And Adrian Simmons just put in the chat a link to an important paper from CDC, which actually speaks to this exact issue. So please check that article out. I think you all will find that really informative. We did get another question about getting full access to the paper and noting that state estimates for hepatitis C prevalence don't appear to be included. And that is correct. This is this new estimate is a national estimate. Eric and I and our team are currently working on allocating this national estimate to states. We started with a conversation with many of our state health department partners to tell them a little bit about the different ways we could go about doing this and to get their feedback, because they really are the end users of these estimates. And so we got some great information from our state public health partners about how we might best sort of allocate this national number to states, and we're actively working on that right now. Those estimates we expect will be up on HepView by the end of the calendar year. So definitely stay tuned for those. And I see that Kathleen, my HepView colleague, put the link to the paper in, and I wonder if it's actually possible to attach the file, because there may be some folks who can't get through the paywall there. So I'm not sure if I'm asking for something that's possible, but if it is, maybe we could just include the whole paper so that people could download it if they want to. Okay, I'm going to go back to the questions. Someone, an anonymous attendee asked whether the presenters think that hepatitis C prevalence and prevalence of risk factors associated with hepatitis C is actually increasing, or if the higher prevalence estimates compared to the 2013 to 2016 estimates are due solely to the new modeling methods. And Eric, maybe I'll ask you to start on this one and then see if anybody else has anything to add.
Yeah, I'd be happy to talk about this from my perspective of like looking at and thinking about these different data sources. And I'd love to hear anyone else chime in as well, just in terms of their understanding of like more recent trends in this epidemic, right? And so that's a really good question, and it's a question that we have talked a lot about within our particular research team. And this was kind of our goal with presenting both of these methods next to each other, is to try to shine a little bit of light on trying to understand this. And what I'll say is, again, I just want to highlight that when we used that similar methodology again that's previously been used, the estimate is pretty similar. It doesn't look to change that much. And as I think everyone, or as we all know on this call, that lack of change is concerning in itself, because of course, since that 2013 to 2016 period, presumably, right, we've been getting more people on treatment. Hopefully we've been curing more people. Unfortunately, but again, thinking about this from population dynamics perspective, some of those people in our higher burden, older age group cohort have continued to die. And so, that maintaining of a consistent, prevalence means there's obviously new infections occurring at a pretty, high rate to kind of keep that balance, if that balance is indeed the case. However, I, very strongly believe, as I tried to outline my presentation that our previous approaches, we have been underestimating prevalence. And so I think, that first result's helpful when thinking about potential trends here. But I gravitate more to kind of our newer approach because I think it's just kind of a more accurate estimation process and a more accurate estimate of prevalence overall. And then the last thing that I want to say, because I do think it's important, these results, we're excited about them. I know a lot of people are excited about them because we just have a general lack of understanding of the magnitude of this burden and changes in the magnitude of this burden on a national level. But they're far from perfect, right? Like this is still our best approach that we have, and it's not super timely. I mean, I'm talking about our new estimates reflected 2017 to 2020. And so I think when thinking about trends, it's useful for looking at these versus previous estimates. But I would almost hesitate to draw the line at reflecting a trend that's happening today, because there have been changes in injection drug use. There have been changes in our, Hep C epidemiology, certainly from 2020 till now, 2024. So that was kind of a long-winded answer. I hope I, addressed kind of the key question there, but I'd be curious to hear if anyone else has anything to add to that.
Sure. Yeah, I can talk about that from sort of a state perspective, because I think you're right that this captures a point in time which is not as current as we would like to see. And this is where I think surveillance data can be really helpful at sort of interpreting if there's a trend there to see, because I think you're absolutely correct that this actually now represents, as an estimate, much closer to what we expect to see for prevalence throughout the country. But I think that these trends are not uniform throughout the country, and there's probably a lot of variability from jurisdiction to jurisdiction. For example, in Massachusetts, we've seen the number of reported new chronic cases of hepatitis C have been declining in recent years, and really substantially. And first, we thought it might be due to the pandemic and access to care, but it doesn't seem that that is all. That probably drove some of it, but not all of it, and that these really are much lower numbers than we used to see on an annual basis. So I think that's partly because we have good access to treatment in Massachusetts. We have substantial prevention programs and needle exchange programs throughout the state that expanded significantly in the last number of years. And we're also probably seeing some saturation of hepatitis C in populations of people who inject drugs. And so I think, the prevalence is not static. And it'll be really interesting to see that with this new and very much improved methodology, what this looks like over time and in comparison to local data and what people are seeing there.
Excellent. Thanks to both of you. So we've got a couple new questions that have come in. The next question is, how can we use these new estimates to convince Congress to fund a national elimination program, and what support can the advocacy community provide? Dr. Irvin, I'm going to ask you if you could get us started on this one.
Sure. So I think the new numbers really help us because it shows us kind of the full magnitude and scope of individuals with hepatitis C, which makes a more compelling case when we're going to Congress talking about how many people we feel are impacted. I think the other issue that it really helps in terms of if we allocate it to different settings, so we think about incarcerated persons, those who are unhoused, then those numbers are higher than we initially expected as well. Because the question that we're always getting is, how much can the scale up be above the status quo? So if we are in the right venues and doing the right outreach, the individuals should be there. So again, I think it makes for a more compelling case for us saying that we can scale up even more if we have the right support to empower healthcare delivery in all of those settings. So I think it helps us. There are a group of kind of advocacy organizations that are being led by the AASLD that have been organizing and kind of writing letters to the Hill, have a Hill Day. And so I would suggest, again, getting in contact with them if any other organizations are interested in those efforts as well.
So much. The next question says, being based on PWID modeling, one would assume that there would be other indicators, i.e. increased PWID numbers would also result in an increased prevalence of HIV, but those increases in HIV prevalence aren't reflected. Do you have an idea as to why that's the case? I can actually maybe get started on that question and see what others have to add. So when we estimated, when we put out the last estimate of national PWID population size, that estimate, just like this hepatitis C prevalence estimate, we believe was an improved estimate over the previous. And so we want to interpret it in the same way, right, as this hepatitis C prevalence estimate. Had we had the information available for the model, this PWID plus model that we created this time, we might have seen, and we probably would have seen much higher prevalence of hepatitis C previously. And so we wouldn't be interpreting this as this large increase in hepatitis C prevalence, which is, by the way, not how we're interpreting it. We're interpreting it as an improved estimate. And that's the same, that also goes for the PWID population size estimate. We hadn't had a new estimate for many years. The previous estimate was basically based on meta-analyzed estimates from household surveys. And so we know that that people who inject drugs are underrepresented in those surveys. And so when we think about the increase in PWID population size, a better way to think about it is really a better accounting for PWID population size. Not necessarily that we've seen this huge increase over time, but that we now have data and methods that allow us to better estimate PWID population size. I think the other thing I would say is that, hepatitis C is so much more prevalent among people who inject drugs than HIV. We do, of course, see HIV in people who inject drugs, and we've seen a number of important clusters of HIV infection over the last, 10 years or so. But those tend to be more tightly networked infections. Whereas hepatitis C is really quite prevalent across the population of people who inject drugs. So I hope that sort of answers your question. Does anybody have anything they'd like to add? Okay, so I actually have one last question, and it's, Dan, this question's for you. So you gave us a very informative talk about the sort of status of hepatitis C surveillance in states and where improvements are needed. For those of you on the call who have not checked out our hepatitis B and C surveillance status report at HepView, please do that. We are monitoring progress in hepatitis C surveillance over time, and we're fielding the last or the current year survey now. So we've got 2 years of data, and we'll soon have a third. But Dan, I wanted to just ask you if you could say a little bit more about what is going to be needed at state and local public health levels if we are to achieve the goals in the ambitious national strategy to end hepatitis C.
Sure, yeah, I'd be happy to. Yeah, I mean, I think what is needed is more resources, and that's largely staff. You need staff who can manage and analyze data. You need staff who can manage the informatics that are required, especially for example, with developing systems to capture these new point of care test results. And you need, if we were to be very responsive to our surveillance data, as I hope we can be for an elimination effort, we're going to need health navigator staff who can reach out to the people who are identified via surveillance and who need to be linked to additional testing or treatment, and make sure that people have access to those services and support them along that road. And I think the number of staff is going to depend on the jurisdiction, the volume of cases in that jurisdiction, and how they're set up to do this. And I think we also need to continue to support jurisdictions in obtaining negative test reporting, that can really change the volume of tests results that a system is processing. So that can involve more resources. And I think we also can't forget that we need to continue to focus on prevention services to reduce the risk of infection or reinfection for the people who are still at risk.
You. So we're right at the top of the hour now, and this will conclude our webinar for today. I wanted to once again thank our fantastic presenters. Thank you all for being here, and also to acknowledge our colleagues at Signal Group for organizing and promoting this webinar. So thanks everyone. You can find the slides and the recording on hepview.org. They should be up as early as tomorrow, so please send those to your colleagues who weren't able to come today. And thanks again.